Day. As Executive Director, I would like to welcome you to Lung Cancer Canada's annual stakeholder briefing. Lung Cancer Canada is a national charitable organization that serves as Canada's leader as a resource for lung cancer education, patient support, research, and advocacy. Our mission is threefold: to increase public awareness of lung cancer, to support and advocate for lung cancer patients and their families, to provide educational resources to patients, family members, healthcare professionals, and the public at large. Collectively, those are the tenets for which LCC was founded in 2002 and why we're here today. November is Lung Cancer Awareness Month, and today we launched the 2019 Faces of Lung Cancer report. This year's report focuses on access, and as we share many perspectives on access, we'd like to remind you that the stories and information presented can influence change. I ask that you support the lung cancer community today by sharing this information, by signing on to our campaigns, and to continue to advocate for screening, access, and research funding, because together we will make that change happen. I'll now turn over the podium to our chair and moderator, CHRISTINA. Thank you.
So good afternoon, everyone. I have the utmost privilege of introducing our panel and moderating this session that will discuss the Faces of Lung Cancer report and its findings today. We have made incredible progress, as Shem was talking about, in lung cancer. The recent statistics showed that we went up a 5-year survival rate of 17% to 19% this year. And, you know, it really does take a village. And in our panel, we have representation from the patients, from the physicians, as well as the team of health technology assessment players that get our drugs into the public drug coverage system. So it is my utmost pleasure to introduce the first speaker here today, and the reason why we are all here, the patients. Anne-Marie Cerato is a board member of Lung Cancer Canada, and was actually the first patient that I met when I started at Lung Cancer Canada. And throughout her journey, I've had the privilege of sharing her wedding, her ability to actually get a mortgage, and with Toronto's mortgage housing prices, and seeing the progress that she has made and the ability that has been afforded to her through access to treatment. So without further ado, I'd like to introduce Anne-Marie Cerato.
Oh, after 10 years, you'd think I know my own story, but I need papers to remember. So good morning, everyone. Welcome, and thank you for being here. 10 years ago, in 2009, I was diagnosed with stage 3 lung cancer. And then in 2011, it was stage 4. That was before I knew anything about driver mutations or clinical trials, or even the fact that the #1 risk factor to lung cancer is having lungs. I didn't believe that I could get married or have a house or travel, because I thought I was only going to live a couple years. I thought I would be like the 21,000 Canadians that succumb to this disease every year. I didn't think I would see my 35th birthday. I was diagnosed at 30, let alone my 40th. But last year I celebrated my 41st, so I'm hoping for 50. I'm lucky though. I have a type of lung cancer that can be treated by one of the many revolutionary treatments that we've developed in the last 10 years. Excuse me. And I stand here today because of those breakthroughs. 10-year survivorship is a huge milestone for a lung cancer patient. I'm a unicorn, and I want more unicorns. More Canadians are surviving 5, 10, and even 15 years with lung cancer and living wonderful lives. Innovative treatments have allowed me to do all the things I thought were impossible in 2011. Like I said, I bought a house. I'm hedging my bets on 30 years, fingers crossed. In Toronto, of all places. Innovative treatments have allowed me to explore life and live life. It's a condensed life, but it's a wonderful life. And they've given me a precious gift that I couldn't even put a price tag on: time. In the 10 years, I've been able to travel all over the world, speak publicly about my story and advocate. It's allowed me to fall in love. It's allowed me to buy the house. And hopefully it's going to allow me to do things that I want to do in the future, like move to Japan for a year and teach. I was fortunate though. I was in the right place at the right time. And if I didn't take no for an answer, I didn't take no for an answer. If I didn't fight for access, I wouldn't be speaking to you today. Luck was on my side again when I stumbled upon information about a new drug. And I pushed my doctors to refer me or give me the information that I needed to pursue that path. I accessed care through clinical trial. I've been on a clinical trial for the last 8 years. Many lung cancer patients aren't as lucky though. Breakthroughs are happening, but our systems haven't kept pace with these developments, and we're falling behind in getting these treatments into the hands of patients who need them. Two of the most prominent barriers are accessibility and affordability. For example, crizotinib, the drug I was on, was first approved by Health Canada in 2012. It wasn't available to patients for more than 1,200 days, almost 4 years. Up until that point, the only resource for patients, or the only course of action for patients, was to withstand chemotherapy, radiation, and surgery. I myself had to do that. When I first began my clinical trial, my treatment consisted of taking 2 pills a day. It allowed me to do all the things I didn't think possible. It allowed me to have my life back. Can you imagine what the freedom means to patients to not have to go to the hospital every day? But lung cancer patients can't wait. They can't wait a year, and they certainly can't wait 4. But not only do patients have to wait, they have to pay. Patients shouldn't be penalized for requiring oral cancer treatments or for where they live. For example, in Ontario, if I needed infusion, I could leave the hospital and never see a bill. If I was a patient in BC and I needed oral care or oral chemotherapy, I leave my appointment with the prescription, have it filled, and not see a bill. Excuse me. However, if I'm in Ontario as a resident requiring an oral chemotherapy, I'd either have to use something that's listed or I'd have to seek compassionate access. That requires my oncologist to have to fill in and fax an exceptional access program application, wait for deliberation, and then if approved, maybe I'd get it. If I had no private insurance, then I'd have to apply for Trillium and wait again. The average wait time for Trillium is 19 days, according to the Auditor General. Sorry, I'm losing my voice. If approved, I'd then have to pay a 4% annual copay of my income on my first dispensation. And I can tell you right now that would literally bankrupt my family. This could have worked in the past and may have worked in the past. But in the 10 years since my diagnosis, 21 new revolutionary treatments have come to market or have been approved. It's not a very user-friendly system or efficient process, and patients don't have time to wait. I do understand that these drugs are very expensive and that we have to do our due diligence when approving them. So I call on everyone, all stakeholders, manufacturers, patients, governments, clinicians to come together, to create innovative solutions so that the right patients get the right access in a timely manner. Thank you. We have no time to wait.
Thank you, Anne-Marie. The next speaker that we have is the president of Lung Cancer Canada and is associate professor at the University of Ottawa, and is someone who is actually also the voice of our new podcast, Lung Cancer Voices. So I encourage you all to listen to Lung Cancer Voices if you haven't heard to it, and subscribe and listen to each podcast, which is focused on a different topic and is released once every 3 weeks. So I turn it over to our president, Dr. Paul Wheatley-Price.
Thank you. I hope everyone can hear me. Christina, is that going okay? You can hear me there? Is that a yes?
Yes.
Okay, great. So thanks very much, everyone, for being here for our annual stakeholder briefing. Thanks to Shem and CHRISTINA for hosting our event, and for the rest of the team behind the scenes who have made this day possible. And of course, particularly to Anne-Marie there for your story of a decade of success with lung cancer. And I came to Ottawa 10 years ago, and much has changed in our field in that time, that mean that there are more unicorns already. And I saw them in my clinic yesterday, and will continue to see them to the point where I'll have to disappoint my 9-year-old daughter and tell her that unicorns actually don't exist anymore. It's just a horse with a horn that is everywhere. I want to talk to you a little bit about, if I can get my slides to work, some of the new treatments and the theme of our Faces of Lung Cancer report this year, which, as you've heard, is access to treatments. So you know that lung cancer is the most commonly diagnosed cancer in Canada. In fact, when Anne-Marie was diagnosed, a decade ago, the 5-year survival was around 15%, and then 17% around 5 years ago, and now 19%. So still a long way to go when we think about other cancers, where breast cancer has an 88% 5-year survival rate of the number of people alive 5 years after diagnosis. Prostate cancer, 93%. So we're making progress, but there is much work to be done. These are some of the stark numbers that you can see in our report. 29,300 cases anticipated this year. In fact, 10 years ago, the number of Canadians dying of lung cancer was around 21,000 then, and it's remained the same now. Actually, there were only about 25,000 cases 10 years ago. So the number of cases is rising as the Canadian population grows and ages. And we're still seeing this huge amount of deaths. 21,000 from lung cancer. If we take the other common cancers, prostate cancer, colorectal cancer, and breast cancer, and combine them, they provide just under 19,000 deaths. So lung cancer is more than all of those combined. More than all of the women's cancers combined. So lung cancer kills more women than breast cancer, ovarian cancer, uterine cancer, cervical cancer combined, meaning that over a quarter of cancer deaths, as you can see there, are from lung cancer. So we have a long way to go, but we are making progress. And this next slide is a little complicated. I'm not going to walk you through the entire thing right now. It's available in the Faces of Lung Cancer report. But this was put together by members of our medical advisory committee, who are physicians of different branches of medicine across the country. And we asked them to tell us a range of services in lung cancer, from early detection through screening, through rapid diagnosis, and some of the molecular testing to identify these novel subtypes of lung cancer, through to different treatment techniques from surgery, radiotherapy, and cancer drugs, and then all the way through to more end-of-life care and palliative care. The green boxes mean that those services are widely available in that province or territory. Orange would mean that it's a bit patchy, depending on where you are. And the gray boxes mean that those services are not available. So, for example, if I draw you to attention to near to the right of there, Nunavut, the territory of Nunavut, there are no specialist cancer services in Nunavut, despite the fact that Nunavut has amongst the highest lung cancer rates anywhere in the world. And so Inuit patients and other inhabitants of Nunavut will have to travel south. Let's go to pick a few rows just to look at now. And if you look at the top row, that is screening. This is probably, well, not probably, this is undoubtedly the single modality which has the potential to save the most lives in Canada. Currently, 3/4 of Canadians with lung cancer are diagnosed, as Anne-Marie was, with either stage 3 or stage 4 lung cancer. But for people who go through lung cancer screening with an annual low-dose CT scan, 3/4 of them are now diagnosed with stage 1 or stage 2, which is curable. You'll see there that there is nothing in green. There are no established province-wide programs. A number of provinces do have pilot programs, and Ontario is probably the leading one there. Now, I don't want to throw everyone under the bus here because we don't have screening already. We should say that lung cancer screening is complex. It is not just a matter of having more CT scans. It's a matter of having a program of what to do with the results of those CT scans. There is progress being made, but we desperately need this to be available nationally for all those at risk of lung cancer. I just wanted to highlight 2 other bits because you can look at this on the report, which is available on the Lung Cancer Canada website and will be available in print within a week or 2. If you go down to just sort of about 2/3 of the way down, there's one row there called oral take-home cancer medication. And you can see that if you go across, there are some provinces which are green and some which are orange, which brings just back to Anne-Marie's point that some cancer drugs are available for Canadians with lung cancer and others have a fight to get that drug. And one of the things that we would like to see at Lung Cancer Canada is uniform access to cancer treatments across the country. With the recent federal election, there's been a lot of talk again about national pharmacare. And one of the things that has the potential to deliver is equity of access to cancer drugs, and particularly this disparity in oral take-home cancer medication. And just finally, I would just take you down to the 3rd row from the bottom of specialist palliative care. And that really still that's not available across the country. And that's such an important element for many people, given the current high mortality rate with lung cancer, that not only do we fight to have people live better and live longer and have higher cure rates, but for those who won't survive the disease, that they have good access to palliative care. Moving on, and I'm just going to be brief on this because we have speakers following me who will go into this in more detail. The approval process is complex and timely. Health Canada will approve a drug for its safety and effectiveness and allow us to prescribe it. That does not mean it will be paid for or covered by any provincial program. So for that, Canada, like many nations, go through a health technology assessment process. And in Canada, that's done by pCODR, the Pan-Canadian Oncology Drug Review, for most of Canada, except Quebec, where INES is the body that performs the same role. If a recommendation comes from pCODR, then a price has to be negotiated through the Pan-Canadian Pharmaceutical Alliance. And you're going to hear from representatives of both pCODR and PCPA when I stop talking. And then finally, once a price has been negotiated and the drug is approved, then it's up to individual ministries from the provinces and territories to add that to their formulary within their own local constraints and budgets. And here is a fairly complex slide. Again, I'm not asking you to memorize these numbers, but this is to highlight some of the timing it takes to get access to these drugs. So in this example, we start the clock in the US when the FDA approves a drug. Now, we can argue whether that's an appropriate start point, but what it does mean is when the FDA approves it, it's because we've now at that point proven that a drug is effective for patients with that type of lung cancer. So we know it as clinicians. Anne-Marie told you that she was aware of drugs and went to her clinicians about new drugs. And so patients and clinicians are aware at the FDA date. And then it takes this kind of range of time, this is numbers in days, until the provinces are funding these particular drugs. And we've just highlighted one there, crizotinib with the 2532 number. That's really to highlight a disparity that in Prince Edward Island was getting the drug 1,000 days, 3 years after many other provinces were having access to crizotinib, which would have been the treatment that someone like Anne-Marie would have wanted to take and maybe did take. And so if Anne-Marie lived in PEI, that would have been a challenge. Let's move on, and we can talk about this in the questions. So just in my final slide, what we want to see is an improvement in all of the advantages and advances that are coming. We want access for screening, huge advance that can save thousands of lives. We want equity and access to medications and to equalize these provincial differences. We want to find a way to afford these drugs, and that will come through innovative ways of working in collaboration with a pharmaceutical industry, with the regulatory bodies, with governments, and with the provinces and with groups like ourselves. We want to have a good sense of what's going on in Canada, and we have Lung Cancer Canada-led initiatives to gather real-world evidence to achieve that. So there's an awful lot going on. There's been an awful lot of progress in the last 10 years. I think you've seen that there's an awful long way to go, but if we work together, I'm really confident for the future. So thank you very much for your time, and I'll hand it back to Christina.
Thank you, Paul. So our next speaker is somebody who's very familiar to health, Ms. Helen Mai. Helen is an advisor of corporate risk at CADITH, where she has worked on a number of policies and procedures relating to CADITH's Pan-Canadian Oncology Drug Review. So before she joined CADITH, she worked at the Ontario Minister of Health as a senior program analyst. She also has a Bachelor of Laws from the University of Windsor, and one fact that you guys may not know is that she was a former respiratory therapist in Quebec. So Helen? So to do this.
Perfect. Awesome. So thank you so much for the introduction, Christina. And really, I'd like to thank Lung Cancer Canada for inviting me here today. So for my part today, I will provide you with really a short primer on navigating through the health technology assessment process. Our objectives will be to focus in on the pharmaceutical space and really provide a high-level overview of the drug approval process, outline some of the key differences between regulatory versus HTA, highlight a couple of key issues that are faced by HTA bodies, and then consider how some of the upcoming initiatives and opportunities could help to enhance and strengthen the HTA process. So for those who may not be familiar with CADITH, which is the Canadian Agency for Drugs and Technologies in Health, we are an independent, not-for-profit organization responsible for providing healthcare decision makers with objective evidence to help make informed decisions about the optimal use of health technologies. And we have a suite of programs and services, but of course, the focus of today's discussion will be on our pharmaceutical programs. So I think in terms of, I'm just gonna go through this really quickly because Dr. Wheatley-Price had provided a really good overview in terms of the context around the drug approval process, around the regulatory requirements for Health Canada, some of the key areas in terms of what the two key health technology programs in Canada, CADITH and INES, and as well as my colleague Rohini will be providing much more detailed description around the Pan-Canadian Pharmaceutical Alliance. In terms of what I will mention in terms of the funding decisions made by each of the independent jurisdictions is that we do have on our CADIF website in terms of the reports on the status of funding. So it's really a loop back in terms of the whole process through, and you can see that on our website. So in terms of from time to time, what we've heard is, what is HTA and how is this really different from the regulatory process? As you can see from this table, it's really a high-level summary table comparison. So the objective of the regulatory approval is really to allow the sale of the drug in Canada. Regulatory approval really assesses whether or not the drug works for its intended purpose, what the risks or the side effects are, but certainly doesn't determine costs. So the objective of the HTA recommendation is really for reimbursement by publicly paid drug programs. And essentially it's for the decision makers to decide whether or not to fund a drug. So the HTA body will evaluate the comparative effect of the drug under review to other drugs as well as other non-drug alternatives. HTA will also assess the value of the treatment. Because of the available resources may be limited and certainly must be allocated appropriately based on the effectiveness and affordability, HTA really helps to inform decision-making by asking questions such as, for whom does the drug work and when? Is it actually better than what we already have? How will it be used? What are some of the potential trade-offs, and so forth. So HTA will assess the clinical evidence, the patient evidence, the cost effectiveness, and implementation consideration to make a recommendation. So I mentioned earlier that we would look at a couple of key areas that HTA body needs to consider and manage. And the first really relates to volume and capacity. So the pharmaceutical programs operates based on a first in, first out principle. So what this really means is that the drug submission process is triggered by the sponsor, which could be for the oncology side, either a drug manufacturer or a tumor group filing the submission with us. So this slide gives you a bit of the snapshot on the potential pipeline of oncology product. And this information is obtained from the Canadian Drug Pipeline Information for Patient Groups. This work was actually a collaboration between us and CCAN, and is currently funded and maintained by the Canadian Partnership Against Cancer. And as you can see from the slide, this shows a rather robust pipeline for potential new lung cancer drugs that could enter the Canadian market. So since the inception of the pCODR process, there certainly has been growth in the submissions for lung indication. And as you can see with the greatest volume in 2018. And to provide you with a bit of context, since our inception, which was our very first file was July 2011, until the last quarter of September 2019, we have about 180 submissions. As you may know, our capacity based on funding is roughly about 20 to 25 submissions per year. And in 2018, we actually received 33 submissions, and we're actually projecting similar numbers for 2019. So this slide provides a bit of a breakdown in terms of the pCODR Expert Review Committee recommendation. And as you can see, the majority were conditional reimbursement recommendation. Certainly, I think the 2019 Faces of the Lung Cancer report provides a very robust detail about the specific indication. So the second key area that we often face with the reviews is really managing uncertainty of the data. So to ensure that there's consistency and transparency of the drug review process, our expert review committee follows a deliberative framework that includes looking at the clinical benefit, the patient values, the economic evaluations, and of course, the adoption and feasibility. So we look at all the elements within each quadrant. And for the clinical, the committee will consider the effectiveness, the safety, the burden of illness, and the need. For cost effectiveness, the committee will consider the incremental cost over effect. In terms of adoption feasibility, the committee will consider the enablers and the barriers to implementation in the healthcare system. And certainly our committee is also focused on the patient-based values regarding the appropriate use and the impact of the drug under review. So in terms of when there's implication, what are the implications when there's uncertainty in the clinical data? And we certainly see that in earlier study phases. Each review is certainly assessed on the evidence that's presented. We know that uncertainty affects patients, physicians, and the healthcare system. So it's certainly a pressing issue for all of us. Uncertainty in the clinical data typically means that the outcomes of the events cannot be accurately predicted. So our expert review committee will consider a number of factors when reviewing clinical information, which may include, but certainly it's not limited to, high burden of illness in terms of prognosis. The evidence must reasonably suggest that the drug under review could substantially reduce morbidity and mortality. Significant unmet clinical need is certainly identified more on a population or subpopulation basis. If there is an absence of clinically effective drug or non-drug alternatives, and if there may be long-term follow-up data to support the review. Uncertainty in terms of the clinical data also certainly has implications for patients. So for example, if patients value better quality of life or to stop or slow progression of the disease, because of the uncertainty of its effectiveness, it would be difficult to assess whether or not it would meet those values described by the patients. Similarly, it would also be very challenging to assess the cost effectiveness of the drug under review if there's uncertainty in the clinical estimates. Uncertainty certainly has implications for the healthcare system as well, because we take the perspective of the publicly funded system as a collective. We need to consider the balanced solutions to manage the uncertainties and certainly to present the best available evidence to support appropriate treatment access recommendations. So what are some of the opportunities? So while we are faced with certainly some challenges, I think it's important to really look at the opportunities that could help to enhance the HTA processes. I certainly outlined some examples here, and each of these initiatives will certainly take more than 10 minutes to describe, to do it justice. But in the interest of time, I certainly will only highlight the key linkages from an HTA perspective. So the first example is Health Canada's regulatory review of drugs and devices initiative, or as many of you may have heard, the R2D2 initiative. And a key area where we have been collaborating on is really around the aligned reviews with Health Canada. And certainly this has helped to enhance information sharing between the regulatory body and certainly with the HTA, because this allows us really to have a better dialogue about the specific review, as well as a bit more specific in terms of predictable timing. So we've also made some operational changes to the pCODR process to allow for earlier discussion at the pre-submission stage with the addition of the provisional algorithm. And the last but not least, we're certainly also exploring collaboration related to the work from the CAN Revalue Initiative, which is led by Dr. Calvin Chan, in particular in looking at how to integrate real-world data into the review process. So in closing, I really like to thank Lung Cancer Canada for bringing us together to initiate these discussions and really to look at some of the opportunities to collaborate on future solutions. Thank you very much for your time.
Thank you very much, Helen. The next speaker that we have up here today is somebody that represents another quadrant of the health technology assessment process, and it's from a pricing perspective. Ms. Rohini Basir represents the Pan-Canadian Pharmaceutical Alliance, where she provides strategic advice and technical expertise to support our 14 public drug programs across Canada. We certainly have a myriad and a patchwork, as Dr. Wheatley-Price was referring to. She is a senior pharmacist there, and prior to that, she worked at various roles at the Ontario Ministry of Health. And one thing that you may not know about Rohini is that she's also worked for several nonprofit organizations in India, where she helped deliver public health services to low-income populations. So please join me in welcoming Rohini as she discusses considerations and challenges from a pricing negotiation perspective.
Proceed in this thing, right? Yes. Okay. This is for yes. Okay. All right, great. Get the slides. Okay. So hello, everyone. I'd like to thank Lung Cancer Canada for inviting me to speak here today. So we'll get going on what I want to share regarding PCPA. So let's try this. All right, here we go. So what I thought I'd start with is just some general information about PCPA. I think there's different understandings of what actually happens at PCPA. So hopefully this will be something interesting for all of you to see. So to start off with, as you can see here, and as Christina mentioned, we have basically all of the provincial, territorial, and federal public drug plans that are part of PCPA. So those are considered the PCPA jurisdictions. And then we have the PCPA office, which is where I work. And so we have a staff of 10 people who are basically supporting these jurisdictions in meeting the objectives of PCPA. So what are these objectives? They are to increase access to clinically effective and cost-effective drugs, to achieve consistent and lower drug costs, to improve consistency in decision-making, and to reduce duplication of effort. This next slide just shows how the PCPA has been evolving. When we first started in 2010, there were only 3 provinces in PCPA, and we were only negotiating certain drugs. By 2015, we had all of the public drug plans in Canada with us, and we were negotiating any drug product that came out with an HTA. And in the last few years, we have seen a consistent increase in the volume of drug products that do come through PCPA for negotiation. And we are dealing with more complex negotiations, including drugs for rare diseases, biosimilars. We also have been trying to collaborate more externally, so that includes industry groups, patient groups, CADTH, ENES as the HTA bodies, as well as PMPRB and international health systems as well. So we continue to grow and evolve. Next slide. Let's see here. So this slide has already kind of been shown by several speakers, so I'm not going to spend a lot of time here, but it does kind of highlight that there are many steps involved with any drug product, and PCPA is in the middle there with jurisdictions afterwards, and so there's that other step that takes place after negotiations, where jurisdictions follow their own decision-making process to decide on drug funding. But all of these organizations do also take into consideration other things that are going on, especially for oncology drugs. PCPA not only looks at what Health Canada has said, what the HTA is saying, but also CDIC is a different body that provides recommendations, and we look to see what they are saying. And as Helen had pointed out, that is something that's transitioning into CADTH. And of course, we take into consideration what patients and clinicians are saying about a specific drug product. All right, so let's get into a little bit more detail about what actually happens at pCPA. So once there is an HTA from CADA or ENES, what happens is the office will contact the manufacturer to let them know that we're aware that there is a new health technology assessment that's come out, and we are looking at what our next steps are going to be. We're going to be deciding whether we will be negotiating on this drug product. So that's the blue section of this slide. Then we move into phase 2, which is the yellow section, and that's basically where the jurisdictions are going to be looking at all of the information regarding this drug product, this indication. They're going to be looking at what the health technology assessment is saying, what the recommendation is, and there are different paths that the drug can take at this point. So maybe there's more information that we need. Maybe we have a health technology assessment from CADA, and we'd like to also know what is happening at ENES. So that would be a case where maybe we want to wait to negotiate, and we may end up saying to the manufacturer that we're going to hold for a little bit and we want to find out some other information. Another way that pCPA might make a decision is perhaps there is a recommendation that came out that says we don't recommend that you reimburse this drug product. So in that case, I'm just going to actually move to the next slide. The decision may be that we are not going to negotiate at this time. And what can happen, there we go. Oops. Yeah.
Can we go back one, please?
So if there is a negative HTA and we've decided not to negotiate, what can happen is the manufacturer may decide to go back to CADA or ENES and resubmit, and there is an opportunity to negotiate at a different time if that health technology assessment is positive. So that there may be an opportunity later. But in most cases, there is a decision made to engage, and so the office does let the manufacturer know that we are planning to engage in negotiations, and that's what this middle area here on this slide is showing, is basically that's when pCPA and the manufacturer work together to reach an agreement, trying to achieve the objectives that I had already highlighted, and really just find the best price possible for Canadians for that drug product. So once we do reach an agreement, then the final stage would be to have what's called an LOI, or a letter of intent. And so that basically is an agreement between the jurisdictions that have participated in this negotiation and the manufacturer that we have reached an agreement on the price for that drug, and now it is left for individual jurisdictions to take that LOI and make decisions on actually funding that product. There is always a possibility that an agreement cannot be reached on price, in which case the other direction that it could go is that negotiation would close. And so we would be letting the manufacturer know that we cannot have an agreement on this drug product. And in that case, if the manufacturer is able to provide the value that we're seeking as far as the jurisdictions require, that manufacturer can always come back and we can negotiate further. Okay. So I want to now go specifically into what's going on with oncology negotiations. So I'd just like to show how 2019 has actually been a record year as far as volume of oncology negotiations. You can see that last year there were around 21 files that were engaged, and that means they were engaged is the word for the negotiation was started. And this year we are already at 30, and the year's not done. As far as completed oncology negotiations, again, we're already around 25 and the year's not done. So it'll be a record high, and it'll probably be closer to 30 by the time the year is over. Oops, okay. Sorry, there we go. Okay, so another slide here that I wanted to highlight is we are certainly aware of the time taken to negotiate has is an important factor, and it has an impact. So one of the things we are tracking is how long it takes us to negotiate. We do have brand process guidelines that we released last year, and in there we do have a goal that we'd like to complete PCPA negotiations within 6 months. And despite the increase in volume that I've just shown you, we have been able to actually decrease our timelines for negotiations, especially trying to keep negotiations within a 6-month time period is something that we're tracking quite closely. Of course, it is really a partnership with the manufacturer to require both parties to work very closely to meet those sort of timelines. And the last slide is just some of the things that we are continuing to work on is increasing capacity and finding efficiencies to manage this increasing volume, as well as the complexity of the products that are coming our way, to find effective collaboration with stakeholders and encouraging innovative agreement approaches, incorporating real-world evidence, as Helen has also pointed to, and supporting biosimilar adoption and cost-effective use of reference brand biologics. That's the end of my presentation.
Thank you, Rohini. We have something very special that we've done today at Lung Cancer Canada. Besides all of you in the room that you see here, we actually have a number of satellite sites where patients and clinicians have gathered in order to listen to the presentations today and be able to participate from a remote area, as well as a number of individuals who are dialing in and listening in remotely. So I'd like to thank those that are in Sault Ste. Marie, those are in Winnipeg and Calgary, to name a few, and one that's in St. Catharines in Niagara. So for those of you that are in remote sites, if you have questions, please type them in, and they will be transmitted, and we'll make sure that we bring them up here in our discussion today. Iwo and the team, Michelle, will have handheld mics that if you want to ask a question, please wait for the handheld mic in order for us to be able to have those that are listening in and joining us remotely to be able to hear the question as well. So, thank you. It's a very complex process by which we get drugs discovered and into the hands of patients like Anne-Marie. I'd like to kick off the questions in the discussion by referring to a term that we've heard a number of times today, and that's real-world evidence. So I wonder if we could go around the panel and really talk about how do we, maybe from Dr. Wheatley-Price's perspective, how do we gather that real-world evidence, how patients can participate, and then from Rohini and Helen's perspective, how that might make a difference in shortening the timelines by which we can get drugs into the hands of patients like Anne-Marie. So perhaps we can start with Dr. Wheatley-Price.
Thanks, Christina. Can you hear me?
Yes.
So real-world evidence is a phrase that probably I hadn't heard of 10 years ago, maybe even 5 years ago. It was just coming into our consciousness. When we hear about the big advances of these drugs that are going through the HTA process and negotiations, that's all from data that's gathered from prospective clinical trials. Maybe one that even Anne-Marie took part in. But we know that patients who enroll in clinical trials have to meet certain criteria of how healthy they are and various other characteristics that mean that a lot of the other lung cancer patients we see in the clinic would not have been eligible to go in a trial. And therefore, there's always been a question about how applicable are the results from a trial to the real world. And so hence the phrase real world evidence is what is the evidence of outcomes from lung cancer and treatment rates among non-trial patients, so in the general clinics. So that could be a number of people in my clinic, which is an academic center where we do a lot of trials, but it could also be in community centers, which I mean, many of them do a lot of great research, but maybe don't have as much. So that's the preamble. So how do we get this data? And the answer is, I'm afraid, it's complicated and it's challenging and it's difficult. But what I can say is that this is a great time to be looking at real-world evidence for lung cancer. We have a number of initiatives that Lung Cancer Canada is helping to coordinate to gather such data, and there are already fantastic initiatives in different places in the country. British Columbia, I would highlight as having some great data sets. Calgary as well has an established database for lung cancer patients. And what we're doing at Lung Cancer Canada is putting together leaders in different centers and in different provinces to develop this real-world evidence. And we're trying 3 or 4 different methods to see what might be the most effective. And what we hope to be able to do is then engage with groups like CADTH and pCODR, with the pharmaceutical industry, with the payers. So we have a good understanding as we go into this, what data is needed. It's no good for us to come up and collect data which is good for clinical research if one of the goals is to have it be good for Helen when she is going through a health technology assessment process. So this is a good time to do this. We need partnerships. I just was having a meeting this morning with one of the thoracic surgeons who's the current president of the Canadian Association of Thoracic Surgery, and they're looking to develop databases too. And so we can combine with all of these to develop the data. So we don't have it right now, but I would anticipate that within maybe as soon as 12, 24 months from now, we'll be starting to roll in a lot of really good quality data.
Helen, would you like to continue?
Thanks so much, Christina. And I would echo what Paul was saying as well, right? This is certainly an exciting time. Paul's right in terms of there are a number of initiatives. I spoke earlier about some of the key uncertainties that we had with the clinical data. So certainly with real world evidence data, I think that will help to support and provide a bit more or to supplement some of the information that we currently have. I also mentioned earlier that Dr. Kelvin Chan is leading a work on around the real world evidence framework. So I think a lot of that work is still at very initial stage at this point, but it is a progress moving in the right direction.
All right, so yeah, I think real world evidence is very interesting. And I think from a PCPA perspective, it would be, if we, as both speakers have kind of highlighted, there's still work to be done to understand how we would gather this information, what information we are gathering, what we are measuring. But once that is kind of further sorted out, the idea of being able to collect this and know whether a certain drug product is really doing what we thought it would be doing, and then setting pricing based on certain outcomes would be a very innovative way to reach agreements. So it's something the PCPA remains quite interested in. I think one of the things that we consider in our lens is, as we look for agreements that are based on real world evidence, the one thing that comes to mind is we certainly hope that the real world evidence is positive and it shows that this drug is achieving what it said it would achieve. However, there's also that possibility that it will not achieve what it's supposed to achieve, and there's a very difficult decision to be made there as well, that at what point do you say this drug is not reaching the performance indicators that were established? And is, like, at this point, I don't see a lot of times jurisdictions actually delisting something because 2 years, 5 years, 10 years from now, it didn't achieve what it was supposed to. And is there comfort with that sort of new process of, yes, something was funded and pricing was established based on that, but now it's actually not going to be funded? That's a very big question with real world evidence. Is that something that people are willing to consider?
I think from a patient group perspective, we certainly only want the drugs that are working and effective to be funded because we all recognize that there's a limited number of public dollars to go around. But perhaps Anne-Marie can comment on what some of those pieces of real-world evidence might be that is things that are important to patients but that are not captured through clinical trials.
Yeah, I think it's. Can you hear me? Okay. I think that patient goals or what a patient wants is sort of the whole purpose of a treatment. So whether it's they want to see their grandchildren go to school or whether they want to get married or whether they want to buy a house or whatever their goal is, I think we should work to achieve that goal. I think real world evidence that could be used is quality of life. And I know that's a really relative term and everyone has a different kind of idea of what a good quality of life is. But I think that marker for each patient is real world evidence. Progression-free survival, again, is something that we can always look towards being effective. Side effects, how they actually affect patients. And again, it's a relative thing. Some patients are going to be tolerant to more things than others. But I think that we can gather that data from patients everywhere. I think that these rare diseases, when we try to, fit them into the same box, or we think we're going to get a phase 3 trial and recruit, thousands of patients, it's not going to happen. We might have 400 patients in all of Canada. So for us to want to measure its success by previous markers, I think we have to change the way we look at things. Sorry, I'm losing my voice. So I think the real world data piece would really help with some of these rare diseases and some of these smaller groups of driver mutations.
So I think the panel here has really highlighted some of the complexities and why we really all need to work together. And it's important to note that the issues that they touch on are not necessarily just lung cancer issues. They are issues that are common to Lymphoma Canada and Jackie from Canadian Cancer Survivor Network or melanoma that's also here today. So it talks about the importance of working together. I'm going to ask Michelle. Michelle, has there been a question from?
There are no online questions. Is anyone?
Louise?
Thanks very much for all of those interesting presentations. I guess this is more a comment than a question, and it relates to Dr. Wheatley-Price's, I think, optimistic vision that pharmacare is going to pick up costly oncology drugs that are not being covered now by provinces. Frankly, I don't see that as a very likely outcome of pharmacare. I think it's going to be, if it ever gets off the ground, which is unlikely, I think, at best, it is going to cover generic and really very basic treatments. So I guess I just wouldn't want to get people's hopes up too much about what pharmacare is going to do to fill in the gaps for us in funding for drugs.
Speaks to the need that we all need to work together and collaborate in order to achieve the outcomes that we want to achieve. I have time for one last question from the floor. Oliver?
Hi, sorry. You appeared right behind me with the microphone. It's very impressive. Hi, so Oliver Johnston with Pfizer. So thanks very much for this great presentation. I just wanted to follow up on some of the discussion that was happening about real-world evidence and incorporating real-world evidence, whether it's into CADTH reviews or PCPA processes. I think all of us in this room are highly, highly interested in this. My question for you is that while this topic's been discussed for years now, any perspective around what's needed to actually take the next step and to actually start implementing this? Like, is this something that needs to start with CADTH? Is it something that starts with the patient community or industry? Interested in any perspectives from those of you on the panel. Thank you.
Dr. Wheatley-Price, do you want to jump in first?
Yeah, thanks, Oliver. Yeah, well, maybe the first thing is I'm not sure that right now we have that quality real-world evidence data to present to the regulatory bodies, and So the first thing is to get our initiatives up and running, and we've got some very nice proposals, well, not proposals, plans that are just starting to get underway, with different ones looking at rare molecular subtypes that Jeff Liu is leading from Princess Margaret Cancer Center. There's a small cell lung cancer real-world evidence database that's going to be led by Dr. Cheryl Ho in Vancouver and myself. There's another group that led by Dr. Pani Chima in Brampton and Dr. Sarah Kuravilla in London. There's also a very interesting initiative using artificial intelligence to try and curate data from multiple centers. So I think there's a lot of really neat initiatives that have not started but are imminently about to start. And because lung cancer is so common, it won't take long for then that data to start flowing. So I think rather than putting too much pressure on Helen to answer that question right now, we've got to kind of give her the data, and then we can put pressure on her and her colleagues to see how they deal with it.
So with that, from a patient group perspective, I encourage all the patients that are listening in and on newer treatments, as when we put out a call for our pCODR submissions, if you please connect with us, please share your stories so that we can add them to our submission and start to provide some of that, not formalized, but in a more informal way, the real world evidence to the pCODR and CADIT team so that they'll be able to understand what this drug means to patients that are living with lung cancer. I lied. One more question from Michelle, who's sending it to us from which city?
This is from Francois Pelequin in
Quebec.
I don't have a place, but it's from Francois Pelequin. It's for Helen. Can you elaborate on how CADIT manages uncertainty? It seems from reviewing recommendations that uncertainty is not exactly managed, but assessed and often rejected.
So I think, again, I mentioned earlier, it's each drug product is presented on its merits, right? And all the facts are presented. So again, it's uncertainty. Yes, there are uncertainties, but there's also unknowns. It's the unknowns that it makes it really difficult to manage.
Thank you.
So if I can ask my team, please, to bring back up our slides. I think we could have continued the discussion for much longer, but in respect of everyone's time and clinicians that need to go back to clinic, I will just close this meeting and just say that it is a start of a discussion, not necessarily the close. And we have a few announcements. There are some evaluation forms at the end of your packages. Please do complete them and give them back to my teammates at the back. I really would like to thank the patients who've given us the privilege of sharing their stories and telling and representing their voices as we fight for access to treatments and other systemic changes and support services for patients and their families. I want to give a shout out to our November the 21st, our Evening of Hope, which is happening here in Toronto. It starts at 6 p.m. Our keynote speaker is Francis Shepard, and we really do encourage you all to join us as we celebrate Anne-Marie's 10-year cancerversary. So in celebration of that, you guys might see here this big white board it's flipped around, and it's like, what is this big white board that's here beside me? So if I can get Anne-Marie to do the honors of flipping this around, because I realize that I cannot move without cutting out on volume here. This is the first ever social media campaign that Lung Cancer Canada is having. I invite you all right now, please, to bring out your cell phones, take a selfie. We want you to shout out to the world that lung cancer patients and their families deserve to live. And it's called the I Deserve to Live campaign. So go on to Lung Cancer Canada by the web link here, sign the pledge form and pledge to support the fact that lung cancer patients deserve to live. 2, create a photo. take it, share it on all your social media channels throughout this month of lung cancer awareness, during Lung Cancer Awareness Month. Tag those in influence. Tag those in government, tag your community leaders, tag your friends and families, challenge them to go on to support the fact that lung cancer patients deserve to live, and continue to using the hashtag of I Deserve to Live. So the campaign officially launches now. We have nothing on the campaign. I invite you all and ask you all to please support it by taking the photo and sharing it out so that our page will be populated by the end of the hour. And I also ask that everyone, if you could stand and we could get a group photo with these I Deserve to Live tag, signs so that we can start our Lung Cancer I Deserve to Live campaign. So with that, I would like to thank all our speakers. Can we get the slides back up? I'd like to thank all our speakers, the patients and clinicians who've worked really, really hard to get us our satellite sites. I'd like to thank Paul Ruth for taking time off of our clinic today. He's actually got a Ottawa Mini Patient Summit who he's chairing at the end of the day today. Thank our panelists for coming and taking the time to explain this complex process, and really it is a collaborative effort. I'd like to really thank our sponsors who have really supported us through this journey for the stakeholder briefing. And oops, I'd like to thank all of you for attending. So now if we can please rise, and we want to go over to the back by the Lung Cancer Canada banner and take our photo and kickstart our campaign. Thank you very much.